Hello, everyone. We're listening to so many stories today from different parts of the world. We had Ireland, Gaza, and I'm bringing you to Malawi today. This is a place where I've been working for the last 8 years. And my talk is about 5 hours, 10 million women. 10 million women. This is the reality of breast cancer care in Malawi, the place where I've been working for those years. And 10 million refers to the number of women in the population. That's about 4 times the number of women here in Ireland, just to give you an idea. And in the country, there are only 2 breast cancer clinics. One is in Blantyre, where Queen Elizabeth Central Hospital lends a few rooms every Tuesday morning for 2 hours. These rooms are usually for something else, but on Tuesday, they become the main place for breast cancer patients. The same happens in Lilongwe, in Kamuzu Central Hospital, for 3 hours once a week. So 5 hours in time, in total. So just to give you an idea of what that means in practice, here in Ireland, for example, we have a population of over 2.5 million women, so a lot less, but we have 8 specialized clinics. We have a big national program with 4 regional hubs, 24 mobile units that go all across the country. So there is a huge difference between Malawi and Ireland. In Malawi, care is really scarce. In Ireland, care is everywhere. You can access these services any day of the week and pretty much everywhere across the country. So a huge difference. And you might wonder as well, what do those clinics look like? And I can tell you from my own experience, visiting the clinic in Blantyre in the south many times as part of my work. The clinic itself is quite simple, quite Spartan, just a few empty rooms. And outside, there is a big space with a number of benches. And every Tuesday morning, there is a long queue of women waiting there quietly. Many of these women come from rural areas, so they have to start in the middle of the night to be there by 8 a.m. when the clinic opens, because they need to start queuing, because if they're not there on time, they might not be seen in these 2 hours, and that means coming back again and again. So they're tired, often they're sick because they already have symptoms, often they have small babies with them because they cannot leave them anywhere else. And also, they might have to borrow money to be there that day. We have to remember Malawi is one of the poorest countries in the world, so a lot of these women come from very poor families. So it's a pretty gloomy picture out there. And you might wonder as well what happens in the clinic. And again, for this one, I can give you the example of a lady who has gone through this clinic. Her name is Joyce. I have personally met and collaborated with Joyce a few years back, and her story is very similar to that of many women like her. She came from a rural village outside Blantyre, and one day at home, she accidentally found a lump on her breast. Now, the lump was small and it wasn't painful, so she just thought, it's just gonna go away, like many of us think when something is wrong. So she just waited and waited, and months passed, but the lump was not going away. So eventually she decided to ask her sister for advice, and the sister said, well, why don't you get it checked at the health center? So she went. And at the health center, now those are very small rural clinics. They're used to see maternal patients or women with breastfeeding issues. They're not really familiar with breast cancer. So even the clinicians there and the nurses, they weren't quite sure what was this lump. So they referred her to the clinic in Blantyre, the one open for 2 hours on Tuesday morning. So she went. And the next Tuesday, she was there queuing with all the other ladies, and she was scared, as you can imagine, because, well, she didn't know what was wrong with her. She didn't know what she would find once she entered the door. She had so many questions in her head. But she was also hopeful that she would find some answers. Eventually, she was called in, and she was told to undress so that she could be examined. And even that was uncomfortable because she had never undressed in front of another man that was not her husband. So she wasn't, again, comfortable or sure what to do, but she just went with it. She just followed what she was told. And after the examination, the doctor told her that she needed a number of tests. Now, when I say tests, that means additional appointments, multiple consultations, multiple trips back and forth across the city. So every single step, every single trip means money, time, and effort, all things that Joyce didn't really have. So you can imagine how difficult was her situation at the time. But she went through with it because, again, she wanted to find out what was wrong with her. So eventually the results came back, and she was told that she had breast cancer, and she needed mastectomy, which is a surgery to remove one of her breasts. And as you can imagine, that came as a shock, not the surgery itself, but even the idea of having breast cancer, because she had no clue what it was. This is not something that is talked about. This is not something that is known in rural villages. The only thing she knew is that some women whispered that this can be caused by witchcraft, or there are rumors that sometimes when you're breastfeeding, if your baby breathes on your chest, it can cause this kind of condition, so all sorts of rumors, and she didn't know what was true or what was false. A lot of women also, when they had health problems, they went to the local traditional healers, which are really common in Malawi, but they seldom got better. So she was worried about herself, she was worried about her family, and about her future in general. But the doctor told her, look, you have to do the surgery because this is your only chance to contain the cancer and make sure that it doesn't spread to other parts of the body. So after a lot of thought, she went through with it. And the recovery as well was not easy because this was completely new to her. She didn't even know how to take care of the wound of herself. Her husband as well was not so supportive because he expected her to continue doing all the things that she would normally do, so cleaning, cooking, and all the things the wives normally do, even though she had the surgery. And in the village as well, she felt observed because now she looked different. She didn't have one breast. So she felt shy and vulnerable. So this was a very difficult journey for Joyce. Things started to slightly change one day when she found out that there was a local organization that helps women like her. So she went and she was given a prosthetic. Now, when I say prosthetic, I mean a very, very simple cotton kind of round shape made by local women. So it was a very simple thing, but she told me that actually that was really helpful because she could put it under her t-shirt, and even though the wound was still healing underneath, at least on the outside, she looked normal. So that was helpful for her. And another thing that happened is that in this organization, she found out that they were organizing survivors groups. So she joined one of those groups because she learned at the time that a lot of women don't even make it to surgery. They die before. So in a way, she felt that she was lucky because she had that opportunity that many others didn't have at all. And that's when I met her, when she was volunteering for the survivors group, and she was doing health talks in the local church, the markets, the bus, wherever she could talk to other women and warn them to go and seek help before it's too late. And she explained to me that that was not easy for her, and it took a lot of courage because these are very conservative places, as you can imagine. And women are expected to stay home, look after the family, not to go out and speak up in public like she was doing. So she had to go against the current to do this. She had to break the social norms, but she felt it was her duty to do so. So that's when I met her, and that was a relatively better period for her because she was happy that the surgery went well. She was happy that she was part of this new initiative, and she was looking forward to going back to some sort of normal life. I went back myself to my own life here in Ireland, and I continued working and following her good work in Malawi. Until one day, all of a sudden, I heard the news that she had passed away. Now, she didn't die because of cancer. She actually died from an infection post-surgery, an infection that kept on coming back, and despite her best efforts, she lost her battle with cancer. So her luck ended that day. And in places like Malawi, accessing care and surviving is often a question of luck. Luck to be at the clinic on time, before it's too late, before the disease is gone too far. Luck to have even the money to make that journey and all the other journeys needed for the treatment. Luck to know what to do, because this is a big hospital. It's a very difficult environment to navigate, and there is nobody there to help you. So many women don't have that luck. If you look at the statistics, the average survival time after diagnosis for women in Malawi is between 6 and 9 months, so very little time. And that brings me to Akazi, the project that was mentioned that I'm part of. Akazi is a collaboration between local authorities, communities, clinicians, and many others to improve breast cancer care in the country. It started back in 2019, and it is a relatively small project, but we are seeing some progress, and it's still running today. So I often think back about Joyce and about, in a way, the manner in which she was able to transform her experience, which is really sad and very painful, into something with a purpose. So by sharing her story with you today, and in general, as part of my work, by sharing our story, I like to think that we are honoring the efforts that she started so many years back, that we're continuing these efforts and spreading the word. And in these years, I've also learned a number of lessons myself personally that I would like to share with you today. These are not about breast cancer. They can be applied to anyone who is interested in working in the international scene and in global health, whether you are a researcher, a practitioner, or just interested in general. And I found them helpful, so hopefully they will be helpful for you too. Number one is the importance of listening. Many of us might have already been doing this job for a long time, so we have expertise, but it is always critical to listen to the local voices first before we decide to do anything, before we design any intervention. Not just the health workers, but also the communities and the people that are living the issues that we're trying to tackle, because they're the ones who are living these realities every day. So they know much better than us what are the gaps, the complexities of these issues, and the solutions that might work. So there is a lot that they can contribute to. Number two, small changes matter. We don't necessarily need big investments or big interventions to make a difference. Even small things, like, for example, an additional well-trained health worker, faster diagnosis, or just raising awareness like Joyce was doing. All those small steps, they look like small things today to us, but they will eventually add up to something bigger in the long term. And number three, humility is key. We have to remember that many of us are not from these communities. Well, I'm definitely not. I'm an outsider. So our role is not to go there and think that we're going to change the world or that we're going to answer all the questions and all the problems that people have. But rather, our role as outsiders is to just listen, support, and stand by those that we're trying to help. So I would like to encourage you today to think about this. How can we listen more to the local voices? How can we find small, meaningful actions that can make a difference eventually? And how can we consider our partners on equal grounds, like we are equal, two-way conversation rather than top-down? So that brings me back to my opening line. We have 5 hours, 10 million women. What can we do with this? It sounds like such a little time to make a difference. And definitely we cannot change these hours because these are public hospitals, so the decision is up to the government. But what we can do is to ensure that women get to the clinic on time before it's too late for them. We can make the diagnostic process faster so that they are starting treatment as soon as possible. And we can ensure that they have the information and support needed to be prepared for the journey ahead. Another thing that we have done, and projects like ours can do, is to create the space to bring people together. We have brought together, as I say, authorities, clinicians, and communities into the same room to share experiences and find together small practical steps that can make a difference. And creating that space, creating those opportunities is another thing that we as a community can do when working in global health. Because all of these small steps will eventually add up, in our case, to more women not dying prematurely, less family suffering, and not relying on luck alone for survival. So this is my message today, that this is the way we can make the most of the little time that we have available. So it's not necessarily the number of hours that define the care that we provide, but it's what we decide to do with these hours. And that's it. I'm going to leave you with this, and I hope you will consider this in your future work. Thank you.